Okay, so obviously I lead the HMR community stroke team. I'm doing a master's at the minute, and my most recent module has been on health economics. So I've used the 6-month review data for that, and I just want to talk you through it because I found it quite interesting. So this is our 2019 quarter 2 and quarter 3 data. So July to December data. And blood pressure was in HMR was a massive outlier. So at 23% I think we were at, and all the rest of under 5%. So I really wanted to compare that with the 2020 data. So our 2020 data, so we were pretty much doing face-to-face contact still, and it's come down quite a lot. It's at about 13% now for blood pressure, but we've got pain and we've got mood, like the overall GM data suggests, higher than they used to be. But the blood pressure still is our outlier. So I wanted to do some work on that. So I've compared the places that we did the reviews as a starting point. So back in, it says 2020, the first one's 2019, all of our reviews were face-to-face. And in 2020, we had a few telephone reviews, and that was not necessarily because of our model had moved towards telephone reviews, but we used it as an opportunity when somebody was having to isolate at home to get a few reviews done. So most of ours were still face-to-face in 2020 at that point. So I just wanted to show you some of the data nationally. So blood pressure in the UK outside of stroke, the QAF data suggests that out of 68 health indicators, it's at 14%, which is the highest of all the health indicators in the UK. So blood pressure isn't just an issue post-stroke, but a massive issue pre-stroke as well. And NHS England estimate that across a population, if we just took 50,000 people, if we did some home blood pressure monitoring, which some of the teams are now doing as part of a little project we're involved in, you could prevent 300 heart attacks and 477 strokes in a 3-year period. So it is really important to be looking at it actually from a stroke prevention point of view. So looking at the impact of re-stroke, which is what we're focused on when we're looking at 6-month review, because we're trying to stop people re-stroking. 23 to 30% of all strokes nationally are recurrent, but not just recurrent, they're more disabling and more fatal than the first strokes, and potentially more costly. Statistically, there's a higher risk of re-stroke in the first 6 months if hypertension is not controlled. A 13 mercury, whatever they're called, in systolic blood pressure, a reduction of 13 in systolic blood pressure equates to a 40% reduction in stroke risk and 20% reduction in risk of coronary heart disease. So it's really important that we're getting the blood pressure down. Public Health England there suggests that there's an opportunity to prevent 14,000 strokes in a 3-year period with better detection and management of the hypertension. So in the UK, it's costing us £4.4 billion to care for stroke patients, and that's the healthcare costs. If you actually add in the non-healthcare costs, such as job losses, benefits, the sort of the informal care costs that are added into it, we're on £9 billion, and it accounts for 3 to 5% of all UK health expenditure. And it's the third cause of death and disability adjusted life years, which means that people are living with a disability and caused by stroke. So the impact of managing blood pressure could have on HMR if we use the 6-month review data. So the figures that we looked at the beginning, we get about 400 strokes a year-ish. If we looked at 20 to 30% of them, that's 80 to 120, have a potential to re-stroke if we looked at the data on how many recurrent strokes there are in the UK. So we've got 13 to 22% of our 6-month review patients with hypertension when we review them at 6-month review. If we can reduce their systolic blood pressure by 13, the risk can reduce by 40%. A 40% reduction in risk is about 52 to 88 patients, of the 52 to 88 patients, which is the 13 to 22%, we could see a reduction in 20 to 35 patients a year having restrokes. So the more disabling, more fatal strokes, we could, just by using our data, if we could manage those patients better, 20 to 35 patients may not restroke, which is quite large, I think. And that's just in HMR. So I've just put in the guidelines here. So different guidelines for different countries. Obviously, we're using NICE, which wants it under 140/90 for adults under 80 years old. And that varies. It's different in America, but NICE suggests that actually some of the methods that are used in the studies in America aren't actually realistic in the clinical setting. So 140/90 is, and under is what we're aiming for. And I've just talked about how to actually take a blood pressure reading in clinic. So if the first reading is above 140/90, we want you taking a second reading. If the second reading is substantially different from the first, we want a third reading. And then record the lower of the last two measurements, and that which Dr. Philip Lewis, who's been helping us out, suggests that you kind of settle down as you get the readings taken, but also the squeezing on the arteries gives you a much more accurate reading by the third reading. Measure both arms, and if the reading's more than 15 different, we want it repeating and then the higher reading used. So actions that NICE suggest: if the clinic blood pressure reading is between 140/90 and 180/120, refer to a GP for ambulatory blood pressure monitoring. Consider the home blood pressure monitoring, which is what some of the community teams are now involved in for at least 4 to 7 days. And a hypertension diagnosis is confirmed if home blood pressure reading is over 135/85. And some of the actions, it's not just all about medications, and we've talked about some of the actions. I think we could be better at referring on for things like exercise, weight management, healthy lifestyle, reducing salt, reducing alcohol. But I think for us, taking medications as prescribed is a really big one, and actually educating patients on the fact that yes, it's a silent illness, but that silent illness is having a big consequence on your life. So so all of those are what the British Heart Foundation suggests we should be doing about hypertension. And that is it.
Fabulous.
I'm back.
Thanks for that, Carolyn. So I think it's really important, this work, isn't it, we're doing? So we've used the data, all you've collected from the 6-month reviews. You've all got it in each of your areas, and like Carolyn's done here, we've looked at their area to see BP was a big, and pain's the other one, isn't it? So you could start off looking at how you could use that data, and by coincidence, we've got this other piece of work with the BP at home to help Carolyn's area address that BP issue in their area. So collecting this data is really valuable, and it's giving you a chance to look at your own actions and what are problems in your areas, and then see from Carolyn's taking that to the next step, which is what we're hoping you're all going to do, and to have more presentations like this. And you may have taken something else which has been an issue with, and looked at that. So Muriel said, you know, that's really interesting. Will you be sending your slides, Carolyn?
So I've sent them to Chris, if Chris doesn't mind sending them out, because he's got the circulation. That's absolutely fine.
So James James asked, do you think the BP at home pilot will be rolled out to more widely? I think yes, James. So we've been on a call before. So this is really highlighted to them, because it was initially meant for GPs, but certainly in my area and Carolyn's area, we're picking up to say what other teams would this be appropriate to. So Catherine, Kane has, I asked on the call if other areas were interested in taking part in this pilot. Could they, you know, contact her? If it's for stroke, then we could think about yourselves joining on from the Stroke Association point of view. You could contact Sarah. Obviously, it'd have to. It's all face to face. But yeah, I do think it'll be big thing. And what the NHS England are thinking of doing is having BP machines on prescription to keep, because it is a real big issue. Chris?
Yeah, it's just to add to say thank you to Carolyn for presenting that, and I think this is the reason we've asked Carolyn to present her work is to and Tracy alluded to it then, in that teams can now take ownership of their own data in their own areas, because like we said at the beginning, it's really rich. Nowhere else in the country's got data like this. And I think Fiona alluded to it earlier with the great relationships Stroke Association have in their areas where they're doing them. I think this adds even more weight now for them teams, such as I know Chrissy Hyde's on Stockport, and you know, to create them relationships where you can actually work together with the Stroke Association now to look at service improvement in your own areas where you may want to, you know, take strides forward, whether it be blood pressure or other aspects that you pick up on in the data. So thank you for, you know, them relationships we've already got, and let's make them even stronger now moving forward.
Super. You know, and a really good example there of you know, what the effect of doing, you know, master's level and things takes you kind of as a practitioner as well, doing that evidence-based reviewing and analysis, because, you know, as part of your project. So just supporting that in terms of developing as a clinician.
I found it really valuable and really interesting to do. It, you know, it's obviously I've given you a tiny snapshot of a massive assignment, but it was so good to have that data as a starting point, because I really struggled to do a health economics assignment without that level of data.
And obviously it's evidence-based practice, isn't it? So you're picking up something that is on a practice level that you understand more than something of somebody else's figures that mean nothing. And that's what we need to do in our NHS services and AHP service, stroke service more often, is this data to influence our practice and change things. Because that's the whole point of why we're doing this whole project. Because my initial question from the start of this was, what's happening in these reviews? What are we doing? We're just seeing patients to tick a box on Snap, so it says excellent. You know, we need to learn, and this is for me a really rich learning environment, which I really enjoy doing. So thank you, Carolyn. It was really impressive.
Yeah, I think the old saying, Tracy, data drives change, you know, it really screams out here. And at the beginning, I mentioned and I said thank you to the Stroke Association reviewers who are involved, you know, actually doing the reviews, because if it weren't for you guys being involved in a project like this and recording the data, you know, collectively across GM, we wouldn't have this data to drive change and present evidence of the future, which Carolyn's obviously doing now as well, you know, part of the Masters. So thank you to you guys who are all involved, you know, in this project.